Welcome, everyone. Welcome to the Implementation Toolkit for Small and Sick Newborn Care webinar. Today's topic is Financing Futures, Scaling Up Newborn Health in a Changing Funding Landscape. Welcome. This webinar will have a live translation to French. To switch to French, click on the globe icon at the bottom of your screen. My name is Dr. Mbozo Sipalo. I'm a clinical researcher and knowledge management co-lead of the Newborn Toolkit. And the Newborn Toolkit is a multi-country, multilingual learning platform for high-quality small and sick newborn care. In 2024, we had over 55,000 unique users from 170 countries, and it's all thanks to you all who continue partnering and collaborating with the Newborn Toolkit. The Newborn Toolkit is a platform where we're moving faster together for newborn health, and it has 1,000 tools in 15 languages, technical content in French, linked communities of practice in English and French. Webinar is on financing futures, scaling up newborn health in a changing landscape. On the screen now, you have QR codes for our newsletter in French, our newsletter in English, and a QR code for our social media platforms, that is Blue Sky, Twitter, LinkedIn, and Facebook. So we have amazing upcoming webinars. Firstly, on 18th November to mark World Prematurity Day and the Toolkit birthday, and to announce our essay winners, we'll be having a webinar focused on that, and this will be our third essay contest. So we all invite you to come watch and come celebrate the World Prematurity Day and Toolkit birthday. And on 2nd December, we have our infrastructure focus webinar to refurb or rebuild, practicalities and costs. And this will be a great time to learn from others and how they're going about building and capacity building for their newborn care in the infrastructure space. Welcome. Please introduce yourself in the chat. And now hand over to my amazing colleague, Lauren, who will walk us through our webinars in French and guide us through the rest of this webinar. Thank you.
Thanks, Mbozo. Alors, bonjour et bienvenue à tous nos participants parlant français. La traduction en français sera bientôt disponible, mais si vous voulez écouter en français, tu peux cliquer sur le bouton de traduction affiché sur la barre de menu de Zoom pour accéder à la canal français. On a aussi quelques webinaires à venir, le 18 novembre, la journée mondiale de la prématurité et l'anniversaire de la boîte à outils pour les nouveau-nés. Et le 2 décembre, l'infrastructure de rénover ou de reconstruire et avec les aspects pratiques et coûts. Alors, next slide, please. So today we're very excited to have our host, Professor Joy Lon. I'm sure many of you have had the pleasure of working with her or are familiar with her work linked to global newborn health. She's a pediatric and neonatal clinician and perinatal epidemiologist with over 30 years experience, notably in sub-Saharan Africa. She wears many different hats and is currently affiliated with the London School of Hygiene, Tropical Medicine, Newborn Essential Solutions and Technologies, and Every Woman, Every Newborn, Everywhere. So without further ado, I will pass over to Professor Joy Lon.
Merci, Lorraine. Bonjour tout le monde. Greetings from Dar es Salaam. It's such a privilege to be here. I think the introduction says I'm a very old person who's worked in lots of places. But I'm so excited to be here today on this very important topic. We do money once a year, and they say money makes the world go round. So maybe 2025 is the year when a lot of money was cut, but the world has continued to go round. So if you go to the next slide, just wanted to start by saying we need to know ourselves, all of us on this webinar today and who stand for newborns around the world. Why invest? Why should we invest in healthy starts? Because we cannot assume that people have a moral imperative to do so. So we still have huge numbers, 2.3 million newborns in the latest UN estimates, and that's been static for 3 years. Also linked are the stillbirths and maternal deaths. So that's the bad news. The good news is most of those are preventable, and that gives us a really big return on investment. If you put money into changing that, you're changing a whole life course. And for example, here in Tanzania, the government investment case suggests that for every $1 in, it's between $8 and $12 return, just in deaths averted, not accounting disability. then countries really care. Countries are wanting to meet their targets, and we'll be hearing particularly from India on exciting progress there on speeding up. And then very importantly, women and babies, and particularly small babies, which is what we work on together, are vulnerable. And they're vulnerable to the many crises we see, whether that's conflict or climate change, but particularly vulnerable to cuts. So in 2025, if we go to the next slide, yes, we have changes, but there are also still valuable data in our last 2 webinars on finance. So on the left, you can see here a webinar about where is the money, which was based on 2 different Lancet Global Health papers splitting out neonatal care investments by donors around the world, which showed limited investment. And in fact, USAID and the UK government was the biggest, and both have cut. It isn't just USAID. And also not enough for research funders. But on the other side, we see that countries are stepping up. It's not all doom and gloom. So we'll be hearing from India, but this webinar looks at Tanzania. And here in Tanzania, there's a very ambitious plan to have 100 new neonatal units. So if we go to the next slide, what's our lineup today? So in this changing environment, what are we going to look at? Well, we have an amazing lineup. So first of all, we have a world expert from WHO who's going to take us through financing options, implications of cuts, and not just admiring the problem. What are ways forward, and what can you and I do? Secondly, we're going to hear from India, who have possibly one of the most ambitious plans, but also investments and change for newborn care. How has that worked? And also maybe what some of the realities within that. We have the incredible Dr. Vivek Singh, UNICEF lead in India, to take us through that. And then importantly, there's only one global fund for women's and children's health. That's the Global Financing Facility. It's relatively new. What does it do for newborns? So we have Mary Kinney, who's going to take us through an analysis on the maternal, newborn, and stillbirth components and quality of care components within many millions of dollars of GFF investment. And then importantly, foundations play a critical role, and also private philanthropy. So we will be hearing from the newly renamed Paolo Chiesi Foundation and their wonderful lead, Massimo. So if we go to the next slide, we're going to start with the fantastic Dr. Susan Sparks. So she is one of the world leading experts on finance and financial sustainability. She's a health economist with 15 years of experience. And as you can see from this, she's worked for many of the big players. And she's going to lead us through what has changed this year, but also what can we do about it. And Susan, we're so grateful that you are joining us, I think from Geneva, and I believe on your vacation. So really deeply appreciated, and over to you.
Thanks, Joy, for the very kind introduction. So I'm Susan Sparks, and as Joy said, I'm on the health financing policy team. And so I want to say up front that my job here is to set the stage in terms of the overall health financing picture, with some food for thought around issues and approaches from the newborn and neonatal side in particular, but in how those fit into the overall kind of fiscal space for health, as we say. So first, to set the scene of where we are, something that I think we all know, but it's important to stress that going into 2025, that health financing, particularly in low and middle income countries, was not exactly on sure footing to begin with. So coming out of COVID-19, countries have been really saddled with just incredible debt burdens, where we see the debt servicing payments more than the entire health budgets in many countries. And so this is on top of what we've seen as a general trend of declining budget prioritization for health. So this means the share of the budget that is the government budget that's dedicated to health. And this is, of course, it goes hand in hand with low public spending on health overall, as well as the flip side, which means that the reliance on out-of-pocket spending, which is, of course, the most inequitable form of health spending, along with this persistence of aid dependency, as we say. So as aid has increased, we haven't seen domestic public spending increasing commensurately. If anything, we've seen the opposite happen over the recent years. And so this is coming into 2025. And of course, then we come into 2025 and we have this aid shock that's come. And as Joy said, it's from the US government, but it's also from many other governments as well in terms of OECD DAC numbers. And so we've estimated, and this is aligned with OECD estimates as well, that health official development assistance is projected to decline between 30 and 40% between what it was in 2023 and what it is in 2025. And I think importantly as well, these numbers are evolving. And so we're supporting a lot of countries through our WHO country offices and our 3-level support. And what we're seeing is that many countries, there's a lot of uncertainty around what that overall aid picture looks like and how to manage it. And that has to do with both the lack of clear communications from many donors as well. We know we have the Gavi and Global Fund replenishments coming up. We don't know what will happen in terms of where that baseline will be, as well as what the actual impact is in terms of funding. Because of course, a lot of the funding that was coming in was running around budgets, was not visible to the governments. And so what we're seeing is a lot of the issues in terms of the concerns and risks around sustainability that many of us have been talking about for years, really playing out in practice. And so we can go to the next slide. So this is just to really hit home this issue around the importance of how to get greater prioritization for health and government budgets. And so these graphs show external aid for health per capita in the green bars. And in the red line, it shows the prioritization. So the government domestic spending on health is a share of overall budgets. And what we see in the low-income countries, so the graph on the left, is that as external aid per capita has increased, that generally, on average, health prioritization has actually decreased in low-income countries, whereas we don't see this trend in lower middle-income countries as much. And so there's a real question of how to change this dynamic overall in these particularly resource-constrained environments. So if we go to the next slide, I pulled out these numbers along with our national health accounts team that show the financing sources for, this is children under 5 years, which of course includes newborn health as well as reproductive health. And in the red circles, so what you see is that of total health spending, that from external sources for children under 5, about a third came from external sources for this population, and then about 20% came from domestic public sources, while the private sources, and so these are really the out-of-pocket payments, comprised almost 50%. And so in this moment where that external share is due to decrease, what we really want to make sure happens is that that private number doesn't go up, because the needs will remain the same. The needs have clear financing obligations associated with them. And there's a real concern about what that shift will be if in the case that domestic public financing doesn't step into that in terms of the real equity concerns and access issues. So if we go to the next slide, this is a slide that Joy very kindly shared with me from analysis that she and other colleagues have looked at in terms of the share of donor funding for RMNCH, and then what share has gone to different aspects of that RMNCH pie. And even within this, of course, and similarly to overall external funding between 2002 and then going into even 2023, what we've seen is this increasing trend on average. But here, while a greater share has gone to newborn health, it still remains a relatively minimal piece of the puzzle. And so I think this really comes back to the issue that this is a domestic public. You can go to the next slide. That's fine. Thank you. This is really a domestic public financing question. And that domestic public financing question, and I think as Vivek, I got in the preparation call, will stress that it's not just about the quantity, it's also about the quality of that funding and how critical that is, particularly in these constrained moments. And what we're seeing is that countries really are trying to step into this issue of what the response to the external funding. So we've seen in Uganda, we've seen in Nigeria, we've seen in Kenya that these commitments by ministries of finance, by presidents, to allocate more money, to give greater prioritization to health in the next budget cycles, and to look to access emergency funding as well in these instances. But of course, these things take time. They are subject to budget appropriation cycles. There's a question of sustainability, but there are very positive signs in terms of that raising awareness. And the raising of awareness really has to happen at the highest level in terms of ministers of finance really engaging with ministers of health, but really presidents and parliamentarians stepping in to have that leadership in response to these dynamics. So if we go to the next slide, what we've been stressing as a team at WHO is this broader picture of navigating what we call the health financing cliff or health financing emergency. And I think this is well aligned with what's in the Newborn Toolkit as well, is seeing how the different pieces of the financing picture fit together. And so there's a clear fiscal capacity question. If this is inherently a domestic public funding financing question, what is the overall tax to GDP ratio? What is the overall size of the government budget? How to engage in that bigger picture. So when you're advocating for funding, when you're considering those issues, how do you make sure it's done in a realistic way and as joined up as possible across the health sector? And then we've been doing a lot on the efficiency and priority setting areas. And so we've been working very closely with our colleagues in the HIV and TB communities in terms of how to prioritize the constrained resources in this moment, in terms of what is that essential benefit package, what needs to be provided, and of course, including their newborn care services. And then an overall moment to really reorient the entire foreign aid structure around health in particular, moving away from parallels and silos and off budget to aligned, system-oriented, using domestic public financial management systems, and then recognizing this is ultimately a political issue as well in terms of advocating for overall greater funding for health. And then within that, how to make sure that the newborn services are protected. So to the next slide, I just have a couple of thoughts and considerations as we go through this webinar and beyond. And so first is what I've already said is this full impact of the aid cuts will happen over time. And as many are seeing in real time, that many of the commodities were already in place. And so what happens in the next appropriation cycles? What happens with the compacts that are being discussed and other processes? And so really it's something that we need to continuously monitor. And then going back to the first principles around domestic public funding. And so while we look for complementary sources, whether it's from philanthropy or from private sector, really making sure that those are viewed as complementary, because we know that in the absence of strong regulation or other policies, that we want to make sure those add to our objectives around coverage and don't distort systems more broadly. And so really coming together in those goals. And really focusing on the quality of the spending as well. While we will be advocating for more funding for health as well, I think we all recognize that there's a lot to be done in terms of the efficiency question. And then really focusing on how neonatal and MNCH services overall and funding, this is a health systems issue. If our health systems are underfunded overall, then we won't have the health workers in place, we won't have the services in place. And so how do we make sure we advocate together? So the last slide, some policy priorities. And so how we come together as communities to jointly set priorities, really focusing as the toolkit stresses on the cost-effective interventions and avoid segmenting of donor through donor-funded activities, and to enhance coordination and alignment and efficiency across the existing funding channels that are already there. So Uganda has a very strong policy around integration, and that integration is done with the recognition that we can't have separate supply chains and information systems and trainings and supervision visits, but how do we bring these pieces together? And then to continue to promote evidence-informed decision-making and the transparency and accountability that goes along with that, and the importance of the research funding as well in this space, because this is rapidly evolving. So how do we build that into these processes? And continuing to focus on more flexible funding and changing financing mechanisms so that the funding that does come in for newborn health isn't stovepipe for particular populations, but can be used more broadly across the system. So with that, I'll turn back to Joy and look forward to listening and learning from everybody. Thank you.
Thank you, Susan. That was really exceptional and such important principles that we stand for here too, that what happens on the newborn ward really reflects the overall system, and that we want to push for integrated funding and changes. And your point about efficiency for all of us. So a message here is the project and doing things separately, whether that's data systems or supply systems, we need to keep the end in mind to integrate from early on so we're not wasting the money that comes in. And I think another critical point about the loss of funding in the lowest income countries may mean more out of pocket for the poorest people, and we really need to stand up to avoid that. So important. And I hope you also heard, for all of us on this call, the opportunity to advocate for change. So I know here in Tanzania, with the election coming next week, the president has committed to 4,000 new health workers in her first 100 days. And I have to say, there's a very powerful Tanzanian advocate, the Doris Malel Foundation, that's at the table trying to see that newborn and maternal is included in that. So all of us can find ways to do that. So going to move from that general financing to the country that has the unenviable #1 for neonatal deaths in the world, but the enviable #1 for the fastest accelerator in the last 5 years for reducing neonatal deaths. So India has a very ambitious goal to get to 9 per 1,000 neonatal deaths, but even lower than the 12. And they've matched that ambition with major investment at all levels. What can we learn from that? How has that worked for neonatal care? So we have the fantastic Dr. Vivek Singh. And Dr. Singh is the lead for UNICEF Health in India, but has also a personal interest and journey and has done so much for newborns across India. He also has an honorary post in Rolling School of Public Health.
Thank you, Joy. And, it's so amazing to see. I'm not just humbled by the introduction of how much you can do helping countries learn from each other. And that's how I have also benefited. And I'm sure the others through each other. And thanks to all that you do. It's my pleasure to be in this panel today. And I'm Vivek Singh, as Joy mentioned. I'm currently also leading the health team in India. What I'll try and do is, it's a very good segue from where Susan left, and especially the policy priorities, which she mentioned around how do we set priorities in certain situations like the current funding landscape? How do we increase efficiencies of the resources that are available to us? But most importantly, how do we continue using evidence and data to gain these efficiencies? And last but not the least, what she mentioned about the flexibility and the innovative ways in which we should be thinking about financing. Next slide, please. So just quickly to put things in perspective, I thought that we should open when we are thinking of financing and what we're trying to achieve. Let's say newborn mortality. Yes, India has set itself, as Joy said, to a single-digit NMR by 2030, which otherwise is a global goal for 2035. So 5 years ahead of the global goal in the SDG, India declared in India's response to every newborn action plan in the India Newborn Action Plan that we'll try achieve this by 2030. Now, just to quickly put things in perspective, India spends, we see what it spends and in terms of the percentage of GDP on health and what it achieves. Nigeria, for example, from the African continent, and then Europe spends about 6.9%, achieves 3 NMR. United States spends 17% and still achieves 3. Brazil spends around 10%. This is the total health expenditure on the GDP and achieves 7. And Australia spends not as much as US, 10%, but achieves 2. So we have to, this is, next slide, please. This is to put in perspective that what are we trying to do with these resources? And for India, the proportion of decline in the last couple of decades or more has been more than the global average and the South Asian regional average as well. Next slide, please. But what has been interesting about this journey is that India is literally a continent with many of its administrative states, so to say 35 plus states and union territories, many of its states more populous than any other country in the world, except for India, of course. So for example, if it's state of the Uttar Pradesh, which is the most populous state in the country, if it were to be a country, it would be the 5th most populous country of the world. So what is important for us to use the resources judiciously is to understand where the burden lies. And I think this kind of data and evidence, and I'm sure each country would be thinking of itself. So for example, in this map, we see in 6 different categories based on the annual rate of decline and what is the current mortality burden. If we can delineate these geographies which need our maximum resources and the health system interventions for universal newborn care coverage. Next, please. So if we go back 2 decades, the financing for health, which includes the RMNCH majorly, has gone up by 5 times. And as Joy was reminding me this morning, the total expenditure is around 4.6 billion US dollars, and sizable part of that goes to child care, and which includes the newborn care. But over the same period, next slide, please. What has also happened is that the newborn mortality has halved. And what has happened with these resources majorly is, if you look at the institutional deliveries, for example, over the successive national family health surveys, it has more than doubled. So basically, it has opened doors for women coming to facilities for quality care around the time of birth, where we can save maximum lives with good quality care, which is delivered with dignity and with equity in mind. So home births essentially going towards facilities, and then a referral loop of care beyond the survival. And what has happened is, if we dig deeper into this nearly 5 times increase, are also social protection schemes. So it's not just the facility investments, but also how to make sure that people travel to facilities. If they have competing priorities, can there be social protection schemes to ensure that they don't choose other options and they go to the facilities? Free services for 1 year of infancy, and has that promoted, and that has actually promoted. So it's not just the hardware, but it's also the software incentives and total social protection envelope around a family and a community. Next slide, please. Then what is also important to understand is, and I'm sure this would apply to countries in the African continent, in India, the newborn mortality range from a state in the down south is 3, literally 3, which is like Europe. We saw Australia per 100,000, and in the highest burden states is 30. So 10 times. And we see the central allocation, how the resources go, but where do they go? They go for catalyzing change in most places, especially where the state and the union, health being a state subject, these resources get combined. And we see the maximum gains over the last couple of days happening in states that have now got a solid foundation built on social determinants around not just the healthcare, but also solid social determinant systems. And then, depending on the per capita investment, now the states are trying to learn from each other, because those that are sitting at the cusp of single digit have states within India to learn from, and those that are above 20 have states in transition who have done this journey to learn from states around them within India. Next slide, please. So if we go to the nuanced mile markers in the financing, let's say we take the case of small and sick newborn care. In a span of 2 decades, India has from scratch, the first unit, zero, first level 2 unit came up in 2003 in a eastern state of West Bengal. And since then, India now has almost all of its 750 districts covered with at least one level 2 care. And the total number of units now have reached 1,134, and which have 12 to 24 warmer beds. But what is more important to understand, and the footfall in these units is about 1.4 million just in the public sector. But what is more important to understand is, for example, the current impetus is on getting CPAP universalized in these units, which we know will be the next bending in the curve that will happen in saving lives in these units. Next slide, please. So I'll continue using the small example of small and sick newborn care. These are 2 successive facility-based operational guidances, which include detailed financing for various components of the health system, as you see in the toolkit itself in the logo. So between 2011 and last year, when the updated guidance have been released, next slide, please. What is important to understand is that there has been advocacy and inclusion of elements for financing for specific components that have emerged out of evidence globally between 2011 and 2024. So you would see that India introduced additional resources for family participatory care, for ensuring that mothers and babies are not separated, as we understood science better, then kangaroo mother care, and then the realization after the recent evidence about immediate KMC to those who are not on life-threatening conditions, those preemies, how can they be roomed in with the mothers? So now these SNCUs are changing to mother and newborn care units across the country. And this is how, with evidence successively, there has been advocacy and inclusion of financing for these various components. Next slide, please. So I'll give an example. When this study was published in the NEJM around immediate kangaroo mother care, many of these units where the study sites were there, one of them was in India, and many of these scientists were there from India. So what they did was they rode on the save wave and continued advocating. For example, to the right, you see the same sites advocated for India immediately investing more resources and ensuring these level 2 cares become mother and newborn combined units. And that's what is happening now and being rolled out with provisions for specifications for finances for units in each of the districts across the country. Next slide, please. So as Susan rightly mentioned, financing is a political issue. So this is something which can be a closing the last slide. How do we advocate? So we reminded, for example, the National Neonatology Forum reminded the then Prime Minister that you need to dedicate resources for newborn if you want early start, not just humanitarian, but utilitarian for your demographic dividend. And then we continued that reminding during COVID, when India was investing 1/4 of health system money it had invested in a decade, that we also need proportion for newborn care, because the gains made would otherwise be lost. So you can see the Union Health Minister with mask on when it was the peak of COVID, sitting with the India Newborn Action Plan in the backdrop and saying, yes, we will be investing much of this money in intensive care units for the newborns. Next slide, please. And last but not the least, we must remember that these are just operational levers or health system building blocks when we are discussing financing. This is necessary, but not sufficient, and it needs to work together with all the other operational levers. We now need to think of innovative financing, models of various stakeholders coming together. What do we catalyze? And then, of course, leveraging technology and all of these other levers, and not just financing in isolation. Next slide, please. And I believe that's the end, that reminding ourselves when the first World Health Report came in 2010 on health financing for UHC, it said it's not just more money that we need. So we could apply it here. It's not just more money for newborn care, but can we get more newborn health from the money that we have? And that's what we should be focusing on. And not forgetting, it's not just the facilities, but the primary healthcare communities, and all sitting together when we are trying to get these efficiency gains. Thank you very much.
Thank you, Vivek. That was really a tour de force of many really important changes. We always wish we had more time. I think you can find a little bit more on the toolkit about India and also in previous webinars. And I would reflect one really important thing is they've kept moving, like the next thing, you know, small and sick newborn care, then adding the maternal newborn units and making that always at scale. And another very important message from India is I think have 1 month of newborn advocacy, which is joined up. You have the Neonatal Forum of India. So the parents, the professionals, the policymakers come with a unified approach, not different voices, which I think we lack in many other parts of the world. So thank you, Vivek. So we're going to move from learning from India and what they have done to really the only global financing mechanism that focuses on women and children. Of course, Gavi, that does vaccines, and the Global Fund, much of what they do has some effect, particularly on commodities. But for the system side and for change, the Global Financing Facility is relatively new. And maybe not all of us understand it. So I'm going to pass to the amazing Dr. Mary Kinney, who's a health systems researcher, the lead for health policy and systems in Countdown with Asher George, and who's a very thoughtful researcher who has been responsible for leading 9 papers across many different teams that have recently landed. And she's going to particularly focus on what does this mean for neonatal care financing? Where does that fit within GFF? What can we learn about what's being done and what could be done differently? So over to you, Mary, and thank you so much for all that you do.
Thanks, Joy, and greetings, everyone. So this presentation is being done on behalf of the Countdown GFF Policy Collaboration, a large team, and there is a QR code that you'll see a couple places and links that they'll provide where you can find more information. So I thought we would start, next slide, please, with just what is the GFF and why we wanted to assess it. So the GFF was launched in 2015 as a new way to fund the health and rights of women, children, and adolescents. It's hosted by the World Bank, and it aims to unite partners behind one national plan, align investments, and mobilize more resources. So this figure that you see is from an early GFF document showing that GFF's contribution in terms of funding is through a multi-donor trust that is linked to an IDA loan, a World Bank project. And the aim is to be catalytic to mobilize additional domestic resources from governments as well as other donors and private sectors. And their goal was to mobilize $57 billion in the SDG era. Click, please. So what did we do? As the first global health initiative specific to women, children, and adolescents, the Countdown Health Policy and Systems Group wanted to learn more about it. And we had done some initial work looking at adolescent health, but we ended up working with a collaboration that started in 2021. It was a group that was mostly African-led, African-based, multidisciplinary group. And I see some colleagues are thankfully on here as well and can help answer any questions. And we conducted multiple studies, and that included 4 thematic content analyses, 4 country studies, and 1 cross-cutting study. And those papers were published in the Global Health Action Journal, and it comes alongside with 3 commentaries, including 1 from GFF leadership, 1 from the PMNCH, and then 1 from health policy and systems researchers in Africa with an editorial. So you can access that. They're all now available online. So today we're going to focus on the maternal newborn paper specifically. Click and next slide, please. So country inclusion. For this maternal newborn paper, we looked at 11 countries that were identified. And this was looking at the initial 36 of GFF countries. We wanted to explore what those country documents look like in the first wave. So we considered documents from 2015 to 2019. And we also looked at countries that were reporting to the Every Newborn Country Tracker and were engaged in different efforts to strengthen newborn health. And overall, we had 24 documents in total. So 11 investment cases and 13 project appraisal documents. And these are the World Bank documents. For the analysis, we assessed the total value of the GFF-linked investments within the project, the World Bank projects, and compared this with the mortality burden. And click, please. And then for the thematic contents analysis, we identified search terms and then set out to understand how those terms and maternal newborn health was described. So this analysis framework allowed us to do it in a systematic way. So we looked at how it was described or framed, considering the mindset. Then we looked at how it was measured in terms of indicators, and then what was the money or the funding and how it was mentioned in terms of the funding. And we took a continuum of care approach, so looking at content in pregnancy, childbirth, postnatal care, and small and sick newborn care. So next slide, please. What did we find? Well, first, there was a lot of money invested in these 13 World Bank projects. So it was $1.9 million invested, and that was part of the 13 GFF-linked World Bank projects. And GFF was a small part of this, as it was catalytic, aiming to be, so $303 million. And for this paper, we compared, the number of deaths and the mortality burden of maternal and newborn deaths and stillbirths with the investments. And we could see that countries with more burden had, on average, more funds, but it didn't correlate when we looked at rates. Next slide, please. This is a little bit small, but I think we want you to see the colors, if you will, more so than all the different documents. But you can see it's all the different countries and then the investment cases and then their project appraisal documents, looking at the continuum, the maternal on the upper part with the blue and then the newborn on the lower part in the purple. And what we found overall is that all of the documents had strong content on maternal newborn health, but generally there was less content on postnatal care and small and sick newborn care. We also identified that across these documents in general, there was fading. So across the M, so while there may be mentions or discussion around the kind of the key themes that we were looking at, when it came to measures, it became less, and then money even less. And so the description of the funding didn't always mention the priorities that were drafted in the earlier part of the document. And then another kind of important finding was that the investment cases we found were these broad investment cases with large results frameworks that was kind of long priority lists, whereas the PADs were more specific. And as we learned through the process of engaging GFF, that the PADs are aiming to just contribute one part of that investment case. And so it made sense that they were a bit narrower, but they also are limited to just a few indicators as these World Bank project documents. And so that can constrain the ability to monitor progress. Next slide, please. We also looked at, what interventions were included or not. And so specifically for newborn health, we saw kangaroo mother care, neonatal infections, and cord care came out strongly. And I think just also to say that emergency obstetric care was also something that came out as quite an important priority within the documents. But interventions were consistently weak or absent when we looked at abortion care, fetal heart rate monitoring, respectful care or family-centered care, postnatal care, support for early initiation of breastfeeding, and midwifery. Next slide, please. We also looked at the outcomes, so maternal mortality, newborn mortality, and stillbirth, to assess how these documents were including the outcomes. And so you can see the red is they were not mentioned at all. The orange was that the theme was mentioned at least once, and that the green is that it was included and it was an indicator or target. And so what we see here is that newborn targets were included in the investment cases, but less attention in the World Bank project documents, and that stillbirth targets remained absent in many of the World Bank project documents and barely even mentioned. Next slide. So some key takeaways, as I mentioned, we did the specific paper on maternal newborn health, but we also had, we looked at it when we were looking across the country studies as well as other thematic studies. And so just some general reflections, the GFF, has elevated the awareness and attention and resources going into women, children, and adolescents. And our secondary analysis of quality revealed that quality is often mentioned in relation to maternal newborn health or separate to it as its own, but it's rarely defined. And we saw very little when it was, described around maternal newborn health. It wasn't related to women's experience, so that was lacking. And then also newborn care, not having any sort of specific quality indicators linked. The third thing here is that newborn health was generally embedded in overall the RMNHC frameworks, but it wasn't being explicitly prioritized for funding in the country processes, and this is despite the high burden. And this came out from the country studies as well. But we did find that in countries, the process around GFF was country-led, but it was highly influenced by power and politics. And some key actors, particularly in that first phase, were excluded. GFF, though, has, in this last point, has demonstrated rapid learning and adoption. And so an example is, the civil society platforms that have been developed in the past 5 years in response to seeing lack of civil society engagement that they've done. And then another important thing was, as we were discovering in our analysis that stillbirths were absent, we learned that they had developed a white paper and had a webinar, and they were trying to sensitize countries to including stillbirths in future priorities. So being very responsive and taking action. Next slide, please. So what? The GFF's future is going to be shaped by the GFF, by the maternal newborn health outcomes will be shaped by GFF. And we know that newborn health is part of maternal and child health, and it seems as if it's still continuing to fall through the cracks in these policy documents. And there needs to be specific high impact inputs for newborn. And now is really this moment, because of the important role GFF has in countries, to assess, to address the policy gaps that have been identified for stillbirth, newborn care, and experience of care, to align investments with burden, and to enable accountability mechanisms. We've developed standard tools to do this, both for the country assessments and the content analyses. And maybe there needs to be some sort of continuous monitoring, like a checklist that's done independent from GFF. And so you can access the series now. It's available here. And next slide, just to encourage us that your voice counts for newborns and their families. Thanks so much.
Thank you, Mary, and such a rich set of analysis, and thank you for doing such a thoughtful and careful review in a short amount of time for what this means for maternal and newborn. So I think here, despite 20 years of some progress on newborn, we're still seeing that the newborn specific part is not there. And that's partly because we're not at the table. So we need to do better as well. And for example, if you read the paper on Tanzania and power at the table, the people who had power, who were at the table, maybe didn't know about newborns, and maybe the people who did know what to do weren't there, and maybe we were on the wards or doing whatever, but parents who didn't have voices. So we need to change that. So thank you, Mary. So we're going to move to our last speaker. We're trying to answer the important questions as we go through in the chat. So I would just honoured to welcome Massimo Salvadori, who is the lead at the Paolo Chiesi, renamed Paolo Chiesi Foundation in Italy, who has a wonderful track record, and particularly appreciate his passion for the gap for French-speaking world. It's the foundation that pay for our translation on these webinars. So very, very grateful to you, Massimo, and over to you to tell us about your unique slant and maybe also a link to the point about private sector that Alex asked about. Thank you.
Thank you, Joy, for the introduction. Thank you, everyone, for being here today to this very important webinar. I want to bring the voice and the angle of the Paolo Chiesi Foundation, but also the angle of the private sector, the philanthropic sector. So next slide, please. Just want to say 2 words about who we are. The Paolo Chiesi Foundation is a philanthropic organization that was created back in 2005. The foundation supports scientific research and development progress in the Global South, and the program is divided into 2 main areas. We have a specific focus on maternal and newborn health, with a focus in the Francophone African countries, and we also have a program on chronic respiratory diseases, respiratory care, in Latin America, Asia, and more recently also in Africa. Next slide, please. Within our maternal newborn health program, the focus of the Paolo Chiesi Foundation is on Francophone African countries, countries that are colored in purple in the map. Here we do the implementation of the NEST, the neonatal essential for survival and thriving model, which is a model created by the Paolo Chiesi Foundation. Is different with the Next 360 is another thing. This model was created by the Paolo Chiesi Foundation thanks to the support of our partners, and the specificity of this model is based on the experience of the Paolo Chiesi Foundation in the Francophone region, and thanks to the support and feedback of all our partners in the field. On the other side, we also have a scientific research program, which is implemented in both Anglophone and Francophone countries. We have the IMPULSE study, which is implemented by the London School of Hygiene and Tropical Medicine. We have the WHO Collaborating Center Bullo Garofalo, and QUAM, which is an Italian NGO, and is a program for improving quality and use of newborn indicators in those 4 countries. Next slide, please. So here I want to share just a couple of challenges as per our experience in the Francophone region. The first challenge is about limited funding and high mortality. So Francophone countries receive proportionally less external funding for maternal and newborn health intervention. So there are quite few organizations implementing partner working in the Francophone African countries, and also few donors. That's why, as the Paolo Chiesi Foundation, we decided to position ourselves within the Francophone region and to support intervention on MNH. This is also linked to the high mortality newborn rate that we are seeing, especially in West Africa, and especially within the Francophone countries. Having a look at a recent report that was sent out by UNICEF, after the consultation, the EWINI consultation that took place last year in Dakar in Senegal, we are seeing that in West Africa, among the first 10 countries with the highest newborn mortality rate, 8 out of 10 are Francophone African countries. So I think here there is a link between funding availability and the high mortality rate. Of course, it's not the only reason, but there are also others, but funding is an important problem. Of course, our response is to support specific intervention on essential care, special care, family-centered care, for example, and zero separation. So these are the interventions that are supported by the Paolo Chiesi Foundation in this area. Next slide, please. The second challenge is about the language barriers. So most of the global health guidelines, recommendation, and publication are mainly in English, and those documents normally are not translated into French, Portuguese, or Spanish. And linked to that, there is also limited access for Francophone institutions and professionals to information and opportunities. So concretely here, Joy already mentioned that, but we are supporting the diffusion and the translation of the small and Sick Newborn Care Toolkit in French. We are supporting the WHO in translating guidelines, protocols, and recommendations into French, supporting the COIN, the Council of International Natal Nurses, the community of neonatal nursing practice, and the training that are linked to that into French. And we're also collaborating with NIA for the organizational development as well in their website. NIA now they have a presence in 37 countries in Africa, and they also have a presence in many of those Francophone African countries. Next slide, please. Last challenge is about unequal research funding. Scientific research funding are concentrated mainly in the Anglophone countries. Most of the resources goes to global North institutions. And as per our experience since beginning of this year, we are seeing intensification of competition between global North and global South institutions for accessing those limited funding. This is another problem that we need to take into account. So even here, our response is promotion of data collection and scientific evidence from Global South, support Global South researcher and co-authorship opportunities. We do also support the participation of Francophone researcher attending congresses and conferences, international conferences, for example. And concretely, we also support the NIA with the Journal of African Neonatology, which is a quarterly peer-reviewed bilingual language journal that is available in the following link. Next slide. I'm also having a look at the time. So I just want to share maybe a few elements about the role of a philanthropic organization like the Paolo Chiesi Foundation. So we are not considering ourselves as a simple grant maker, but we do play a catalyst role. So here I think it's important to play a role of connecting initiatives, actors, and resources across the region, and also creating that link between the Francophone and the Anglophone community. This, I guess, is quite important. As a philanthropic organization, we have the freedom to innovate and to take risk. So basically, we are the freedom to support locally led solution and pilot program, for example. We don't have that role of coordination, but we align our intervention with governments, donors, and stakeholders, and we have the capacity to talk with different partners at different levels. And last but not least, the philanthropic sector has the responsibility to put resources where the needs are. And I think we can play an important role in building a new ecosystem for maternal and newborn health. The private sector can do their difference, and I think the Paolo Chiesi Foundation, but also other philanthropic actors, they can do a difference in building a new ecosystem. That's all from my side. Thank you very much for your attention, and back to you, Joy. Merci beaucoup.
Merci, Massimo, and really thank you so much. And such an important topic. I'm sorry that the time was compressed. It doesn't reflect the importance or the value to you and the foundation. I think many posted in the chat how much they appreciate you addressing this gap area. So I think we're at the end. Alex, you were very prolific in questions, and some managed to be answered, some didn't. So happy to chat at another time or follow up by email. All very important, including private sector. Maybe we can just move to the next slide. First of all, I want to thank all the speakers. I mean, what a tour de force of really important topics. Then welcome you all to come to the next two webinars. Hopefully next time Align MNH won't put a sudden webinar just before the toolkit one. We weren't able to move because I think that only came a couple of days ago and maybe affected how many people came today. So we'll do our best to align. These are really exciting topics, and first official World Prematurity Day. And the infrastructure, we get this question all the time. So should we refurb, should we rebuild? You know, how much to rebuild? What's the return on investment? How to make the case? Floor plans are downloaded from the toolkit. It's not efficient if everybody starts from scratch, right? So please join this and also put in your ideas. And if we move to the next slide, we really want to thank both those who have been part of this, the toolkit team who are gorgeous, Mbozu, Lauren, Roisin, many others behind the scenes, Thank you for that. And please do join us and amplify what we do together, because we are faster together. So thank you so much. And we will close there with much appreciation to everybody, and also to the funders, including Chiesi for the French translation and Beatrice for her work. Merci, Beatrice. Thank you all.